Hello, I'm Michael Brown, Master of Science in Healthcare Management, class of 2007. I live in Massachusetts and I am the current chair of the Alumni Weekend Committee. Welcome to one of this year's Lightning Talks, a series of short talks given by alumni focused on this year's alumni theme of Public Health Through the Life course. We are joined today by Dr. John Robinson, Masters of Science in Healthcare Management, class of 2004, and current Chief Medical Officer of First Choice Health in Seattle, Washington. In his role, John is responsible for medical management, which includes utilization management, case management, predictive modeling analytics. His talk will focus on the analytics that First Choice Health developed during COVID. John?
All right. Thank you very much, Michael. Thanks for inviting me. This is a great opportunity to share what we've been working on at First Choice Health. So the talk today that I'm going to go over is how employers can confront epidemics and pandemics using data analytics. So here's the problem we're facing in the world today. How can employers help their employees navigate their life course through these immense problems? And so in the background there, I've got an image of epidemics versus pandemics, which is pretty obvious to the audience, but the little white spots represent epidemics, and the giant red one, which is more global, is pandemics, as we all are experiencing today. So the technique that I used to work with this is called data analytics to identify at-risk employees. The image on the right is just a spreadsheet, and the white area is the identification of the employee or the member. The green area is the different risk factors, and the blue area is the risk factors being weighted to give us a total score on the right. So the red area there is the highest ones when it's sorted. Part of the scores that we use is a predictive modeling technique called MARA, which stands for Milliman Advanced Risk Adjusters. And each different employee has their own risk score. We use that, and in addition, take demographics and chronic conditions from medical claims, and then I developed a point system for the risk stratification. Now let's see how they're used. So the first problem we're going to go over is the opioid epidemic. And this is one, again, everybody's familiar with. It is severe. There's some numbers on the left to show how many overdose deaths there are. There's a graph on the right, and it's showing what's happened over the last 20 years with opioid deaths. You can see any opioids has gone up. A big part of that is synthetic opioids like fentanyl. Then heroin is down there, and commonly prescribed opioids. So the first thing we did was we developed a report for the employer. We called it the Workforce Opioid Use Report. And this is a simple report that any employer could use to see, do they have an opioid problem in their workforce, which is real important for productivity, absenteeism, and health of their workforce. This was a free report we developed. The company needed at least 200 employees because we wanted to preserve identity of the employees. And what we would do is if a company wanted this report run, we would then request a de-identified version of their pharmacy claims report. And again, de-identified, we didn't want to know any members' names. We had four opioid metrics that we used in this screening report. And these metrics come from the BRIE Collaborative. There's a little insignia over there on the bottom left. This is an organization in the state of Washington that has done a variety of great reports. You can look them up online. Just type in BRIE Collaborative opioid, and you'll see the opioid metrics. There's 9 of them. We slimmed it down to just 4 to make it a screening report. And we started to do this, and what happened was King 5 News, you can see their insignia right over my head there. King 5 News is the NBC affiliate. On their morning news, they asked me to come on and talk about it. I'd never been on TV before. It was kind of a fun experience. And anyway, it got the word out for as a public service sort of thing that we wanted to help. And then after doing that, we also made a larger report for our regular clients. This is a 9-metric report, kind of a population health view. We've showed the components of the stratification on the left side there, like how much opioid are they taking? We call a morphine equivalent dose, sedatives, multiple prescribers, multiple pharmacies, ER claims. We have that from medical claims. We could look for street opioids and heroin that way. Anyway, a lot of different factors go into the stratification, and then we can risk stratify the group. When we did this, we presented it, and a lot of our clients are actually hospitals. We take care of their employees. And they came back to us and said, okay, John, this is nice. It shows that we have a problem, but what are you guys going to do about it? So we developed another program, and this program is called the COPE program, stands for Chronic Opioid Pain and Education. And as most people know, with chronic opioid use, about 75% of the time it's for chronic pain and 25% of the time it's for addiction. But we risk stratified them irrespective of which group they're in. And then my case management nurses, which are really, really good, they started calling these employees that had this high overdose risk and started to talk to them about this problem and our concern and how can we help? Can we help get you into treatment? And sometimes we would need to talk to the pharmacist, sometimes their physician who's prescribing medication. Anyway, we reached out to a lot of these employees with this risk. Some of them were pleased to get the call and to have somebody to talk to about this because they're hearing about it on the news and in the paper. We started to do this around 2018. It was before COVID, but the engagement rate to get them into a program to help them with their opioid use was low, and that was very disappointing. And then COVID hit, and it was all consuming. Employers switched their emphasis immediately to COVID because it was such a huge impact to the population. And like I said before, many of our clients are hospitals, a huge impact on hospitals. You can see the severity here. This is over a couple years, and the blue area, that's total deaths. You can see up to 632,000. That was close to the end of August, and the deaths per day, about 1,100. That's like a 7-day average. It's a big problem. And with the Delta variant, coming back strong, it's not gone away. So then we did our risk stratification again, just like we did with the opioid one. Now we're using medical claims, pharmacy claims. We have a lot of different components in that green area on the spreadsheet there. We looked at age, 21 different at-risk medical conditions that we got from the CDC. Race, smoking status, residence, if they're living in a nursing home or a long-term acute care facility, that puts them at increased risk. What is the COVID rate in the county where they live? We're in 8 states, so we had a variety of different communities. And then we also had some positive factors to help to reduce their score, such as, did they get the vaccine? And what's their state vaccination rate? If they're living in a state with a high vaccination rate, that can also decrease their risk. So we put this all together, and then we decided, well, what are we going to do about it? Now we know which employees are at high risk, that if they get COVID, they could have a severe illness or even death. So I, again, sent out my case management nurses to start calling these employees with these very high risks. And I want to say, when I say employees, I'm actually including their dependents too, because they're also included in First Choice Health, which takes care of self-insured employers. But anyway, when they made this initial call, they would educate them about their high risk, because they're hearing this on the news that COVID's bad, but they don't really know what their risk is. So now we can talk to them about their risk, how to stay safe. We sent them a face mask. We got things going. We did this started in December 2020. And the response was good. The employees were pleased to get the phone call. Occasionally one say, I already know about this, but to really go over their risk was a little surprising for some of the people. So here's some results. Now, we've got a couple different groups of results. The first group of results I'm giving out is from March. So we've been doing it about 4 months. The vaccine is out at this time. So we looked at that. We have about 80,000 people in our database. So when we risk stratifying, we looked at the highest risk, the top 40, right at the very, very top. And how many of those top 40, how did it affect them? Now, they've been contacted by our case manager. They're saying they're at high risk and please be safe. So out of those 40, only one of them had a COVID diagnosis. Nobody was hospitalized. Nobody died. We also looked at how many had received the COVID vaccination. So there was 12 of them out of the 40, and that's about 30%. we thought it was probably higher, but we're going off of claims data here. And sometimes people would get a vaccine that doesn't show up on claims data. And sometimes claims data is a little slow to come in. So we felt it was probably higher than that, but that's what it was in mid-March. And we felt really good about that because only one of the high-risk members had actually contracted COVID and nobody died. So that was good. And then things started to look better at the beginning of the summer. As everybody knows, we thought, wow, we can come out of lockdown. Things are looking good. But it wasn't. Delta came on, Delta hit. Again, it's causing hospitalizations are going up. There's a group out there that, is unvaccinated. That's very concerning. So we ran our data again. Now, this time we had 101 people in that highest risk category. Out of that 101, there was 5 of them that had a COVID diagnosis, and that's like 5%. Number hospitalized, there's only 1 person out of that whole group was hospitalized. They were in the ICU for 10 days, but recovered and came out and is doing well, and nobody's died. The vaccination rate, again, has been hard to get. I've got my staff looking for this. I can tell you a little bit of information in that the 8 people with the highest risk, out of those people, 1 of them was not eligible for case management, so we couldn't contact them. So that left 7. Out of those, 4 of them had been vaccinated, and 3 of them said no, they weren't vaccinated. And that was by a verbal response, not by claims. It's frustrating. The nurses would counsel them to please go get vaccinated, but there's personal choice here, and some of them will and some of them won't, even after they knew they're high risk. So we still felt really good about this program. We're not seeing, there was only 1 person hospitalized out of that whole high risk group, and nobody's died. So we're still reaching out. And we hope to have a good result at the very end. However long this goes, some people say maybe another year or 2. That's discouraging, but we'll hang in there trying to keep that high risk group as safe as possible.
Well, thank you, John. That was wonderful. Some very impressive data. Did you have a sense of what the outcomes would have been based on your model if you hadn't done the outreach? I know it's great results, especially no deaths is wonderful. What do you think it might have been if the outreach hadn't happened?
Well, we really don't know, Michael. We wish we knew. We can't take all the credit for this. There's so many people working on this to try to get people vaccinated, and it's not just us. We're just one of the groups out there trying to help. We felt that personal touch may get somebody who is kind of on the fence to get them over there and say, well, you really are high risk. We really want you to do this. We care about you. We're hoping that was enough to get them out there and get them vaccinated. But for sure, we don't have any data what it would be like otherwise.
Okay. You're dealing with very sensitive data, obviously with opioids, as well as in this political environment, everything is sensitive. I'm curious, you said generally you got a good reaction, but did your care coordinators have some challenges with people pushing back, not wanting to even talk about it, or feeling threatened by having someone reach out on these topics?
For the COVID ones, no. For the opioid ones, yes. There was definitely some pushback on the opioid side. Some of them they're just unfortunately happy taking their opioids, and some of them didn't even answer their phone. And we sent letters, they didn't respond. It's definitely a tougher group to get through. But the COVID ones, almost all of them at least would talk about it.
Okay. And you mentioned that this data says employees, but you said it's all the families. Was the education, I'm not sure you have data on this, but obviously your risk is affected drastically by the people in your house. And if high risk people can get people in the house to change their behaviors, their risks drop pretty drastically as well.
For sure.
Was that part of the education? And if you had any response in that regard?
Yeah, we sure talked to them about that. I don't have information in the data to divide those 2 groups, but I think that's another thing that we can sure look at. But yes, we would talk to them about the whole risk of everybody in the house, keeping people safe.
Okay. Well, John, I want to thank you for your presentation today. It was fascinating. I'm sure it can go on forever. Hopefully this pandemic won't, and we can put it back in history, but it's wonderful to see the work that you're doing and the difference you can make. So I want to thank John for joining us today. I also want to encourage our audience to check out our other lightning talks and to participate in the live panels that will be held during Alumni Week. So thank you.
Thanks a lot, Michael. Bye-bye.